This episode of The Dental Guys is brought to you by the Dental Crafters Network, your implant restorative connection. From surgical planning to patient-specific guides, quality implants, and final restorations, the Dental Crafters Network provides one relationship with infinite possibilities. Call 1-800-472-8302 today. That's 1-800-472-8302. You're listening to The Dental Guys, episode 52. Too many overdenture options, too little time. An interview with Darin Dichter. Darin Dichter from Spear Education joins us again this week to continue our conversation on full arch implant restorative options. We dive directly into what options Darin prefers for fixed versus removable situations, discuss how to decide on overdentures versus fixed restorations, and also discuss which materials should be used against each other to minimize long-term complications. It's time to get your verification jigs and monomer out, folks, this week on The Dental Guys.
Welcome to this week's episode of The Dental Guys. I'm Wes, the Dental Guy.
And I'm John, the Dental Guy.
John, you just got back from an amazing trip with your associate. Tell us a little bit about what happened.
Yeah, it was I've been involved with Spear for a long time, and of course you have too. And I started, one of the first times that I got, I think, really excited about getting into it was going out to the campus and seeing a seminar, because there's a lot of excitement and you got this cool place, a lot of people, big names speaking. And so my associate, who's been with me now a little while, we went up to DC to the first seminar that he's ever been to, the first Spear seminar. And so we went up to DC. It was the Art of Treatment Planning, a case presentation. So it was Frank and Greg Kinzer, as well as Ricardo Matrani was there, which I had not seen him speak before. So that was you remember the first time you got to go to a cool treatment planning seminar like that, and it just, your mind kind of gets blown. And They said it several times, but it's like drinking out of a fire hose. But I don't even get into that because that's a whole other topic. But let me just talk about the stage. Like, we walk in the room.
That's the first thing you said to me. I'm working at the office, and you were like, dude. Spear spared no expense here.
Yeah, they brought the whole show. Like, they have these giant SPEAR letters lit up on the stage. And I mean, it was a little rock star, you know, and I was kind of impressed by the whole deal. I mean, they really got the excitement going. Not quite as cool as maybe the campus, just because campus is cool. But he was just, you come back from that, and we're sitting in the car on the way home, and I'm like, so what'd you think? And he's just kind of like, where do I start? Where do I start? Yeah, so we had like 6 hours on the way drive back just talking about. How was that
conversation, though? I mean, seriously.
I mean, it was intense. It was a lot of like really challenging. You could see like wrestling with, what am I going to do with this? Because he's seen me doing this, but he's like, okay, so now I understand a little bit more about why, once you know some of the stuff, you can't just come in on Monday and look at it the same way.
Either you choose to treat it that way, or just refer it to you. Right, John?
Well, I guess there's always that. Yeah, but it was, I'm trying to get him just, to be always on the same page.
Well, he's coming along at least, right?
He's coming along.
To go through this course, and that's exciting.
Well, speaking of Spear, speaking of
rock stars.
And speaking of rock stars, yes. We have a very special guest with us today, and you guys who have been listening to the show over just the last few weeks heard him once before. This is Darin Dichter, and Darin, welcome to the show. We're glad to have you.
Hey guys, thanks for having me again.
Yeah, we really
back on the show.
I know.
Yes, my second time.
He came back, so that says something.
Back.
Yeah,
I mean, wow.
But we had this whole when we first talked to Darin a little bit. And, Darin, of course, we're these guys, that are talking about, and he's like, I don't know what to expect. These guys,
we are crazy. The Dental Guys.
Right. So we sent him this outline of what we thought we might be able to do in one show. And about like 25 minutes into the show, I'm looking at Wes on as we're
No,
recording.
I
I'm
started
going,
typing because Ryan, our editor,
Yeah.
he was like, Wes, can you not type so loud? I was like, I
Right.
was telling John we're not going to make
Wes
it.
is clanking on the keyboard. And Darin, it was because, things we realized we were getting into some really good stuff.
Yeah, it's
And
good.
so we really wanted to have you back because we talked about some, I think, basic kind of ideas behind treatment planning and some, some not rules, but just some ideas on how to approach looking at number of implants for certain types of cases, looking at how do you start thinking about these cases. And then we talked a lot about just how do you start to learn how to do some of these complex, but we really didn't even have time for what most dentists want to talk a lot about, which is materials, which is, selecting different types of restorative materials. And I really think we want to just dive into that a little bit. And once again, for those of you who haven't heard Darin, tell us a little bit about what you teach there out at Spear, just for anyone who's maybe listening to this show who didn't hear the last one. What is your area of kind of focus there in teaching?
Yeah, thanks for bringing that up. The the area that I've really been, I guess, kind of focusing on over the last couple of years is this area with treatment options for the edentulous patient or those patients, who are going to be edentulous pretty soon. So for the last couple of years on campus, I've been teaching in a 3-day hands-on workshop covering this kind of material. And then more recently, you guys mentioned my colleague, Ricardo Mitrani. Ricardo and I have put together a 2-day seminar that covers this material. So
Gotcha.
that's where a lot of my interest, a lot of my energy has been going. Of course, I'm in, I think, essentially all the advanced workshops. So you mentioned Greg Kinzer a minute ago. I'm in workshops with both Greg Kinzer and Bob Winter. And I think Bob and I, we're counting, Bob and I are together something like 100 days a year now, or a little over 100 days a year. So I spend a lot of time with Winter, and it's great. Yeah.
Oh, yeah.
So I think the thing that we wanted to kind of move to today was John and I visited often. Every year we go to the Academy of Osseointegration meeting, and it seems like that every year we go, there's some, paramount statement that's kind of a consensus amongst different lectures or forums that we attend. And one of those that John and I kind of picked up on was there was several people that were lecturing that were talking about full arch prosthetics and material choices. We have such a breadth now of material choices for our patients, and we wanted to kind of, with you, run through some of those, first starting with fixed full arch implant restorations. This would be something that is implant supported and non-removable for the patient. And we have kind of a full list here to kind of go through and maybe talk a little bit about maybe which one's your favorite and where you would see that being used. And then we're going to get into some tougher questions towards the end of the show, and that's kind of the meat of the show. So we'll start with fixed, and then we'll go into removable full arch restorations, and I want us to kind of lay out some maybe just little pearls of where we think that these restorations fit inside of this our treatment plans for our patients. So,
Yeah,
John,
awesome.
why don't you kind of introduce the first topic here?
Yeah. So the first one we'll talk about, and it's really one of the oldest and first kind of go-to for fixed restorations is a milled bar, or what used to be a cast bar, but a bar with acrylic and denture teeth. It's been around for a very, very long time. There's obviously some pros and cons. Darin, would you say that in a full arch fixed type of situation that you still favor a bar and acrylic for a lot of cases? Do you find that that's being used less? Kind of where do you see that in the continuum?
Yeah, it's a good question. So, you're asking about basically what we would describe as a fixed hybrid. So it's a, it's basically denture materials that have to have some sort of a rigid structure underneath to keep it from breaking. Because if you just were to take acrylic and attach it to the implants under function, that's not going to last very long. So this fixed hybrid, depending on if we're in the maxilla or the mandible, it's what's actually in the mandible. It's been around. It's what the original design from Brandemark, right? It's been around a long time. So what's happened since the 80s, though, is we've kind of gone to using this type of an approach in a bunch of different ways. So in the early Brandemark days, everybody was really freaking out about making sure that we had a passive fit with the metal framework, and that the load would be applied to the implants axially. So intentionally tilting an implant, if you tried to bring that concept to somebody in 1987, they would have looked at you like you were insane.
Right.
But today we do that pretty routinely, and there's a bunch of good research to indicate that tilted implants, as long as they're connected rigidly across the arch, they're going to be as predictable as anything else. So in many ways, it may actually be better because we can save the patient the necessity of a sinus augmentation lots of times. Many times we can get longer implants, and then ultimately we're potentially improving the AP spread. So where does this fit into kind of the spectrum of things for me today? It depends if we're talking about the maxilla or the mandible. In the mandible, I think it's a really nice approach, because a lot of times we're finding in an edentulous patient, the posterior mandible doesn't have a lot of vertical bone left, and it can be challenging to try and find good sites for implants in the posterior mandible. So to be able to either use a prosthesis that we can cantilever or that we can tilt to improve the AP spread, either one of those designs can work really well in the mandible. And the reason that I like it for the mandible is we don't have to have the acrylic in proximity to the ridge. So
That's
we
good.
can go back to kind of this original high water Brandemark design, where we've got 3 millimeters or so of a hygiene space between the base of the prosthesis and the soft tissue ridge. You can't do that in the maxilla.
Right.
And so
and then let me ask you just real quick on that. When you're doing your design for the mandible, where you can use this, or where you like to use this, how do you design the intaglio surface if you're using a bar with acrylic? Do you like to have metal opposing tissue, like a Montreal style bar design? Do you prefer to have acrylic underneath the bar so that it's maybe a little easier to reline the prosthesis? Does that matter if you're trying to leave that hygienic space? Because it doesn't seem like there's a lot of discussion about that, and maybe not a ton of evidence, but I wonder what your thoughts are on that.
Yeah, I don't think the literature is really clear on that. So what that's telling you is it's going to boil down to the preference both of the clinician and of the patient. In the laboratory, it's a little bit easier to go with a wraparound type of a design where the acrylic would be kind of totally encompassing the bar. The risk with that is the retention, the ability to create a retentive form to the bar to hold the mass of acrylic and keep it from actually rotating around the bar over time or breaking apart. So in a perfect world, I would have metal adjacent to the soft tissue side, the intaglio side.
Gotcha. And I know I kind of cut you off there. So you were moving into what some of the limitations of the maxilla were. So I'll let you continue on with that discussion.
Well, I was just going to say that, there's some big differences between the maxilla and the mandible. And one of the primary ones is the way that the maxilla resorbs once the teeth are lost is totally different. And so in the maxilla, we're typically trying to fight a horizontal resorptive pattern.
That's exactly right.
You've got control over that if you're taking a patient who's got a terminal dentition and they've still got some bone present. Then those patients we can control a little bit better. But, a patient who's been a dentulous for years, right, that ridge is going to be challenging to create a receptive site for for a fixed hybrid because you just don't have running room to bring the contours of the prosthesis back to the ridge in a way that will touch the soft tissue ridge, right? So that there isn't going to be air and saliva escaping as the patient's talking or as they're eating. So the design in the maxilla is totally different.
Well,
And
you end up,
really,
I think, let me just kind of explain something for our listeners, maybe some younger listeners and even maybe some seasoned clinicians, is that, we know that the maxilla resorbs, from the that they lose that buccal plate, and that starts to fall back towards the palatal side. And so to regain the loss of tissue, bone and soft tissue, you have to cantilever the prosthetic to the anterior. And what Darin's saying here is true, is that cantilevering, an acrylic prosthetic forward to regain what was lost, especially in some of our severe atrophic cases, this becomes quite a bit of a problem to restore that. You're restoring someone's tissue with a prosthetic. And so
Right.
I
And it
think
almost always ends up in a ridge lap.
Yeah,
In order to close that speaking or fix that speech issue that you mentioned with air escape. So that kind of brings us maybe to that next material that we had on the list, which is monolithic zirconia. And of course, monolithic zirconia has been, especially of late in the last 6-7 years, maybe has come on stronger, partially as a result of marketing, partially as a result of some real advantages that it has. But I wonder, Darin, how does the availability of zirconia, just following along with the same discussion we had, does that material change your preferences for use, comparing that, to your bar with acrylic? I know obviously some of the same limitations are the case for the maxillary arch, but how do you feel zirconia fits in compared to the traditional fixed hybrid?
well, one of the advantages to an acrylic and metal fixed hybrid is that it's really easy to repair.
Mm,
It's also relatively inexpensive compared to anything else that we're going to be talking about that we're going to be using for a fixed application. So it kind of fits those two sweet spots nicely. The main challenge is that the fixed hybrid that's got metal and acrylic is going to require the most amount of prosthetic space, way more than anything else that we're looking at. So where zirconia fits in for me, and the thing that I really like about it is I don't need as much vertical or even horizontal prosthetic space. Still need some, but it's way less. And so that then in conjunction with the fact that the material is super dense, it's got a nice response, soft tissue response, and then we can control it in a lot of ways. So you could decide to do a cutback and layer more of like a feldspathic porcelain on top of that, both for the gingival aesthetic and for the tooth aesthetic. So has potential to be a super aesthetic material. I mean, you can have some really gorgeous outcomes. But the big disadvantage with zirconia is, number one, it's more expensive, but number two, and probably more importantly, is that it's super unforgiving. So
mm-hmm.
you're as a clinician, the impression that we make and establishing the really precise relationship from implant to implant to implant in an edentulous arch is critical. And it's not like we're trying to get a passive fit because we're trying to preserve the implants. With this material, if we don't have a passive fit, it'll crack as you go to torque the abutments down.
Right.
So it's just, again, super unforgiving in that way.
Yeah.
Where are you using this product now?
I like it in the maxilla. I like it in the maxilla. And one of my kind of go-to recipes right now, and I guess that's kind of the way I think about it is recipes, right? So if I have something in the maxilla, then I want to make something in the mandible that is compatible with that.
Mm-hmm.
And so where I'm thinking today is I like full arch zirconia in the maxilla. I'll do kind of a micro cutback, preserving the functional surfaces in the monolithic zirconia, and then layer feldspathic on the facial surface to improve the aesthetic. And of course, I like to layer the gingival ceramic as well. And I think, that's really what separates kind of high end stuff from middle of the road aesthetic outcomes is the transition between the prosthetic pink and the prosthetic white part of the
Yep.
restoration,
Yeah.
right? This prosthetic cervical margin it's really tough to do in a way that's believable, and so that's for me it's kind of fun. And then
And you,
opposing that in the mandible of conventional fixed hybrid can be a really good answer. And a lot of people would think initially, well, I don't want to do that because I've got a maxilla that could potentially overpower the denture teeth on the mandible.
Yeah, but
But
don't go there yet. Don't go there
okay,
yet.
all
Because
right,
yeah,
I don't want
that's
to
a
give it
question.
away.
Yeah,
yeah, we're
later
coming.
part of
We're
the
gonna,
show, we're going to
All
talk
right.
yeah,
about
we're
two
going
unlike
there.
materials. Yeah.
All right. So
But
stay
but
tuned.
you're that's exactly the kind of discussion that led us to,
Right.
as we've talked a lot about that. And let's come back to that
All
because
right.
that's a great addition to that.
But John,
Uh,
this next one.
Yeah.
So there, we saw some people talking about milled chromium cobalt, milled titanium, because they were doing a lot at this particular clinician seemed like at the AO was doing a lot of rescue cases where you had multiple implants that you didn't want to remove that were from maybe the 90s or 80s and that you were utilizing them, but you didn't have quite the vertical dimension of occlusion. And this particular clinician showed very thin castable sections of chromium, or not castable, but milled chromium cobalt in occlusion where you might have like a metal occlusion or occlusal surfaces and then bake ceramic on the outside because, the VDO just wasn't there in some of these rescue cases. And then this pressed porcelain or even stacked porcelain on the facials of the anteriors. I mean, it looked like some of the most amazing things you've ever seen. It looked as good as any or better than any zirconium prosthetic that I've seen from the highest end clinicians. But what are your thoughts on milled chromium cobalt? I mean, it's one of the most expensive things to do because of all the, this large titanium thing that I get concerned about is this large titanium or large chromium cobalt, restoration that has to be baked and fired multiple times and all the expansion and contraction that goes on. Like, are we getting microfractures whenever we're firing this porcelain multiple times to get that layered effect that we like to see?
Yeah, with a big chunk of metal, or even if you were going to do a lot of layering on a monolithic zirconia restoration, right? The name of the game is slow temperature changes. So it's going to go
Yeah.
up in the furnace real slow and then come back down, and that's we've identified that with zirconia because it's such a huge mass of material, and you wind up with some residual stresses that can lead to just kind of like spontaneous veneering porcelain fracture with zirconia. With full arch metal, it's actually not as severe as you'd think because our metal technology, the bond between the ceramic and the metal we've been doing that for 70 years. So the problem with rescue cases is typically you don't have control over the amount of vertical space that you're working in, and so the minimum space, my go-to material is like a PFM type of an approach, like layered ceramics over high noble or noble alloy. And so that's going to typically be cast for me, and then I have to go back in and correct for casting error, so distortion that happens and all that. So it's a really traditional crown and bridge approach. The problem is you can't take a puck of a high noble gold alloy and mill that out. It's a super wasteful technique. It's efficient because a machine is doing it, but you're just throwing away tons of material. So imagine taking a gold bar, go to Fort Knox and take a gold bar and then put that into a 5-axis mill and hit play.
Right.
I mean, it's ridiculous. So cobalt chrome is a material that we've also got a lot of experience with, and some of the other base metals are showing back up too. We've got really good ceramic technology that can bond to those materials. Titanium, I don't think we're there yet. Titanium, um, because it forms spontaneously an oxide layer that can get really thick, it challenges technicians and guys who are trying to figure out different types of protocols for layering ceramic on top of titanium. It's getting better, but if I was going to put a full arch together today, I wouldn't want to use titanium and then try and layer ceramic on top of it. I would go to my go-to is going to be a high noble gold alloy, but I know a lot of guys are using cobalt chrome today.
Gotcha. And so if, if in your situation, you've just, we know, and I've seen, a lot of guys from like at Boston, there's several guys that are big, high noble gold, direct application of porcelain and show some beautiful full arch cases with, like you were talking about these cases where you may have 4 or 5 Brandemark implants. You may now have 2 new Straumann implants or whatever it is, and you're trying to make all this work together. And it was interesting. We with the AO, this last AO meeting was really the first time we saw chrome cobalt from the podium being advocated, and it was a couple different people. And Atlantis is one milling center that is really pushing this now as an alternative because costs are lower than high noble. But and I've just done a couple of cases now. In fact, I've got just a small like 4-unit case that I did with them with chrome cobalt. And I mean, I have to say, the fit was awesome. Then again, it's one case. So I hear what you're saying. It sounds like you'd rather you know that a post solder approach is going to work if you need it, and so you just have the castability, the predictability of high noble is there. I mean, do you feel like chrome cobalt is something that we should be looking at for these rescue cases, or do you feel like we should still be kind of living in that world of high noble gold because it's just proven?
That's a really good question. First of all, we're talking about rescue cases like there was already some kind of full arch situation on top of the implants, and now we have to go back and rebuild it. The more typical way that people get into this scenario is with patients who are partially edentulous and have
Totally
implants
true.
placed while they still have some teeth.
Yep.
And so then they lose the last couple of teeth, and now you got half your implants aren't deep enough to do anything but something
It's
like a
becoming
layered
a
ceramic.
That's
huge
becoming a
problem.
huge problem.
Man.
Yeah, so an alternative to cobalt chrome, if you've got enough space, could be zirconia, right?
Mm-hmm.
Right.
Mm-hmm.
So that's certainly an approach. Ricardo, and I think globally, cobalt chrome is a really popular material to work with.
Mm.
One of the huge advantage that we haven't really hit on yet is the fact that it's coming off of a mill, right? So there's not going to be any dimensional change from casting it.
Mm-hmm.
And the nice thing about that is the fit is usually going to be totally passive.
Mm.
So then the name of the game is just like don't screw it up, right? As you're
Right.
up and down in the furnace, you want to minimize any chance of creating a distortion there. But typically, there isn't going to be any residual stress left over, and so there, if you manage it okay in the lab, I think you're probably going to be okay. But because I don't use that material every day, I'm not familiar with laboratory protocols or where the
Sure.
risks are in the lab.
Yeah, I
Well,
think
if
that's
we
what. Go ahead, John.
I was just going to say, I think it's a good discussion because it is definitely a newer material. And well, not a newer material, but it's a technique that's being used by some people all the time. And then other people kind of say, well, that's just not the world I'm living in. Well, let's kind of maybe go, since those are some of our maybe more common or frequently discussed materials. I want to just move into, before we go to the removable, some of the materials that are out there that are maybe a little less common, but are being talked about a little bit in the literature as alternatives to some of the more common ones that we've talked about so far for fixed. And that would be, there's some discussion about newer composite type of materials, PMMA like materials, or PMMA itself. There are some interesting discussions about that. Do you feel, Darin, that there is any material that you see out there for long-term use that you've seen any literature or you feel excited about at this point as an alternative, or do you feel like those standard ones that we've kind of covered for fixed are about where we're at right now?
Well, I think uh, Today, the full arch monolithic zirconia or zirconia with just a kind of a micro cutback in the facial is now fairly well established. Avi Bidra, who's the director of grad pros at UConn now,
Yeah.
he's got a series of articles that are coming out. I guess maybe this one is just one article, but they went back and did a retrospective study from one laboratory following a strict protocol. These are monolithic arches, but they retrospectively looked at over 2,000 arches over the
Hmm.
last 5 years. And it's almost 100% success rate.
And that
So
was with which material?
that's with monolithic zirconia.
Wow, that's impressive.
So that's, I mean, that's what we're comparing against. So almost perfect. Now, the bulk of these cases were only 3 years out. So 3 years, you can make almost anything work at 3 years. So what we'd like to see is this at 10 or 15 years out. How's it look?
Yeah.
But if you can take a monolithic restoration and get it to go 10 years, and if it breaks or fractures, you either repair it or you make another one based on the original design, that's a lot easier than going back to the drawing board and casting a whole bunch of units and starting over.
Yeah.
So how does that work against some of the newer materials? And there's a whole new class of materials that are coming out for this application that are kind of generically grouped as high performance polymers. And so PEEK is a material that most of us are familiar with from temporary abutments. PEEK is falling into this category. PEC is another one that's got a little bit of a different chemistry going on to it. And PEC is probably the material of this family is the one that I'm most familiar with. But it's got some really good numbers to it. It came over from aerospace, and the idea is it's got like a super killer strength to weight ratio. And so if you imagine feeling in your hand a full arch of monolithic zirconia, it's actually like it's heavy. It's in your hand and it feels heavy.
Yeah.
Where the PEC material, it's actually really light, and so it's more closer to what, in terms of weight, it's more closer to what it's replacing. The challenge with any of these materials is there's like no literature for this type of application. So just
Yeah.
earlier
Right.
this week, I did another lit search for this stuff, and there's a couple of case reviews looking at individual, not like 10 cases, looking at one case and not how did it work as an outcome. It's kind of like how easy or how difficult was it work in the laboratory.
Yeah.
And there's some big advantages in the lab, right? You can mill it, you can press it. We're not too far away from being able to print it, but I have no idea what it's going to do in the mouth.
Yeah.
So right now, I'm like, I like the material. I think it looks good. I've got friends who've got a couple of arches out. I'm looking for some cases because I want to try it. But we don't have anywhere near someone publishing 2,000 arches and saying, here's what it looks like between 3 and 5 years. We're just like nowhere near that kind of information.
One thing
Yeah.
that I think that's missing from, this whole fix situation is, not everybody gets, not every patient, they walk into the office and they go through a workup and, they have the all on six done. And in fact, we load these immediately a lot of the time because of the initial stability of these root form implants. And the thing that's awesome about that is that patient walks out with teeth and they're wearing that prosthetic and most of the time the occlusion, you balance that out and get that all worked out within the first few weeks or two, and then time goes by and the implants integrate and just like you'd want them to, and here we are at 3 to 4 months and we're ready to move forward with the final prosthetic, and then life happens. And whatever that is, they're not financially ready to move forward with the next step. And the next step generally is one of these things that we've been talking about here in the beginning of the show with these fixed implant full arch restorations. And I remember hearing Lyndon Cooper talk about the poor man's hybrid as a alternative to just leaving someone in a PMMA that has no rigid, substructure to it, and we have a high risk of fracture. And that's not a fun day whenever a large fracture happens, and it happens to be in the anterior. And how do you repair that? And Lyndon brought up a good point that he did at UNC Grad Pros, was that he did this poor man's hybrid where he cast a metal frame and laser welded it to cylinders, and then did basically a bar wrapped in acrylic. And the problem that is a cheap way to provide a rigid substructure, Darin and John, but the problem that we still see is it's very labor intensive. And is there anything that you feel like, I know you've mentioned these newer materials that you feel like that are on the horizon, that we could maybe give our patients to help them get over that whatever life threw them, and to maybe hold them off until they can afford maybe to move forward with this next step? That's a tough question, right?
That's a tough question, because really, I guess what you're asking is what's the least kind of, I don't know, I don't want to say the cheapest, but what's the lowest end that you're willing to?
Right, it's a get you
accept?
By thing
Yeah.
that's better than the
and
PMA.
maybe you say there isn't anything, and that's okay.
That's
okay,
we're because we don't know, and our lab guy doesn't know either.
We talk about this from time to time when these cases roll in, and then they can't complete the final, and we're trying to think about what can we do in these cases, or if it's an older patient who's maybe not as healthy.
90-year-old.
Yeah, I mean, what do you do in cases if health issues take over and you can't, I don't know. Is there an answer for that?
I think I would take it back another step and say that should be part of the discussion during the treatment planning and the case presentation.
Okay, it's fair.
Just like, imagine that this is a reconstruction on teeth. You're going to do a upper and lower reconstruction on teeth. Your patient gets into provisionals and says, hey, these look pretty good. I think I'm going to chill out here for a while. Like, you don't want that. The teeth are going to decay out underneath, and there's going to be other problems. So, like, my fees for that type of an approach aren't going to be, here's what it's going to take to get you like 30% of the way, and then we'll sort out what's going to happen after that. No, I think
it's good advice.
Yeah.
And I think that's a very good
That's
point.
What our listeners need to hear.
If they're not ready to pay for the case, then maybe we shouldn't start the case.
Maybe we shouldn't start it.
Because if there's a complication, right? Imagine you lose an implant, or it's going to take more time, or you find out that the implants went in at an angle that you weren't planning for, and you have to scramble that way. Yeah, I think it's critical to not just have the conversation with the patient about what the overall case fees are on the restorative side, but here's what you should expect surgically. Here's what you should expect looking forward in terms of maintenance costs. Because we know things are going to happen, right? With a fixed hybrid, the teeth are going to wear out eventually. If you're 90, maybe not, but if you're 60, yeah, for sure. So you got to know that there are more fees coming down the road. And so part of that is going to be routine. Part of it's going to be me taking it apart, cleaning it, changing screws and doing that kind of stuff. Part of it's going to be unexpected. Teeth break out over time. So, you got to be ready for that.
Yeah, and I think that's point well taken. And I think we need to be okay with the fact that when we're presenting these cases to patients, we need to be sure that they're ready to follow through, because things are going to happen even when we do plan. And if the patient's not financially ready, especially, that's a big problem. So we're going to move on to talking about removable, and we'll spend a little less time because those, I think, will roll through a little bit more. But first, let's take a little break to acknowledge one of the sponsors of the show. Well, Wes, we've been talking about, obviously, in this episode, options. And there's
a lot of options.
And it's kind of overwhelming. And I think what we need is somebody who can help us to make sense of these options from the lab side of things, so that when we look at these cases, we have someone who we can talk to figure out what's best.
Well, don't you love it whenever you tell a patient, I work with a team of people, and the people on that team are, one, you, the patient, me, kind of like your go-between, but who's making the actual prosthetic? Your team member also is the dental lab.
Right.
And unless you have somebody that understands lip support and bar overdentures and telescopic copings and all these things that we've been discussing, I mean, you're really kind of starting off behind the eight ball, as they say.
Yeah, and I think that that's one of the benefits of the Dental Crafters Network is they've got people there
Knowledgeable.
who, I can call and I can say, I'm not really sure what to do here in this case. It's got a combination of like 3 different types of implants, and some of them maybe I have a little bit more vertical clearance than others. These ones are angled, these ones aren't. What are my options?
People talk to me about like their lab experience with some of these cases, and it's just not good. And listen, if you've got, I mean, I understand some of you are passionate about what lab you're using, but whenever we started working with the Dental Crafters Network years ago, my experience was always calling them and saying, what do you think about this? Because of their knowledge base,
Right.
that they're always looking and understanding, or at least trying to understand, what these complex treatment modalities bring to the table.
Yeah. So I think that if you don't have a resource that can help you through navigate these waters, you really need to give the Dental Crafters Network a call. And I would mention when you call them that you heard about them on this podcast, the Dental Guys podcast, because we want to make sure that they know where you're coming from. Plus, they're going to know exactly what to talk to you about. Because if you say, hey, I listened to this podcast about removable versus fixed implant options, they're going to know exactly what you're talking about. They're going to know who to get you to talk to. And the way you can reach them is to call them at 1-800-472-8302. That's 1-800-472-8302. The Dental Crafters Network. One relationship, infinite possibilities. So after that really exciting message, we want to dive right back into removable, because obviously there's a lot of good information there on fixed for you guys to digest. But with removable, it's equally complicated. And I think first I'm just going to kind of list some of the things that are out there, because we don't want to get too much into the high weeds. We may talk more about some of the details on these, but let's go through some of the things I know. Darin, I may miss things. I want you to kind of add in things if there's other options that you prefer or that you know about. We've got one of the things you hear about the most, bar, which is tap for retentive elements, milled bar that's tap for, say, locators. We're seeing a lot of that these days with milling. We've got spark erosion, secondary bar type of techniques. We've got unsplinted attachments, such as locators, which we touched on a little bit in the last show. We've got the conus type of technique, whether it be the precision conus like what Atlantis does, or whether it be just the traditional conus or that type of idea, some type of rigid unsplinted. We've also got the good old hater bar type of approach with cast or milled. Darin, I know there's other things out there. Are there other options that you see out there that you're using? Kind of tell me a little bit about with that kind of list or adding of your own. What are you using? What do you prefer? What are your thoughts on some of these different options out there?
Yeah, it's a really good question. I think that the biggest challenge with the removable on top of implants discussion is, how do we even make sense of all this? Because just what you said, there's so many options.
Yeah.
And, kind of everybody gets figured out quickly, okay, locators could work. But then what happens when locators don't work? Or a patient comes in who's previously been treated and has some attachments that you're like, I don't even know what this is. So one way to think about it is how much room do I have? What do I have for prosthetic space? Because, at the end of the day, with all of our treatment planning, I think it's fair to say that we'd like to be able to meet the aesthetic and the functional demands of any given case as conservatively as possible. So I think that's particularly true with our removable patients, because these are people that we're going with removable because they've got some kind of a horizontal deficiency in the residual bone relative to where we want the teeth to be. And so kind of like the last thing I want to do for these guys is sacrifice bone vertically if I don't have to. So we can think about, these different restorative options with respect to how much space they take up, or what's the minimum amount of vertical space. And That's where locators really hit the sweet spot, because what's that, 10 to 12 millimeters?
Mm-hmm.
Really nice. So some other individual attachments that we could use that fall in that same kind of space range would be a custom telescopic overdenture approach. We could use different individual attachments that have some resiliency, like O-rings on top of a ball attachment. Um, but when we think about adding a bar, the bar, just like with the fixed hybrid, the bar is going to take up a ton of space. So bar overdentures, all of a sudden, we're back needing the same kind of vertical space that we do for a fixed hybrid. So 15 to 18 millimeters is the number that everybody talks about. Once you have a bar, a bunch of different ways to use it, but it's the space thing that first gets my attention.
Yeah, yeah. Now, given that you have, let's just throw up. Obviously, we could get into a lot of hypotheticals, but given that you have enough vertical for any option, okay, what
It's Disney World.
it's yeah. You just exactly. It's
you got
like the
everything you
fair,
want.
the county fair, Disney World. It's all right in front of you, and it's all free. And you can just pick whatever you want. Do you have some go-tos that you really prefer? Tell us a little bit about that.
Yeah, in the maxilla, my training and I guess my current belief is with resilient individual attachments, there's risk to the osseointegration. There's risk to potentially overloading the bone implant interface. So you won't see in my work, you don't see a lot of maxillas that have, 4 or 6 locators attached to them. That's personal preference, because if you go to the literature, you can find articles that will support with really good long-term data that doesn't happen, that locators work just fine in the maxilla. So I guess the big downside in the maxilla with locators is when locators get out of parallel, the locator attachments wear much faster. So the
Mm-hmm.
maintenance requirement goes way up. So if I've got implants that I can get parallel, I can go with a prefabricated type of an approach. So let's say locator. If we're in the maxilla and I've got implants that aren't parallel, typically flaring out towards the facial, well, or this happens in the mandible too, right? So if I've got implants that aren't parallel, that's when I would think about going with a custom bar. Doesn't have today. I don't think many people are casting those. They're typically going to be milled, but a milled titanium bar or even cobalt chrome bar will allow you to correct for the angle. Comes at a cost, though. The cost is vertical space, but it does allow you to angle correct. So if I have to angle correct, even in the mandible, that's when I would be thinking about a bar. And so you asked about my preference, though. My preference today, I'm leaning towards a telescopic type of an approach. So I favor a custom approach, but they're going to be custom abutments that are individual direct attachments to the implant with an overdenture that's going to be held on those abutments with a friction fit. So it's
So this is
functionally
conus, but
yeah, it's going to be similar
customized.
to conus, but customized.
Hmm.
So
Okay.
So
So
it's
so tell me about the design
Yeah, that's what I was
of
gonna
those
say.
abutments.
well, first let me tell you about the advantage to this
Yeah.
is you put a bar overdenture in for a patient. There's a bunch of different ways to retain the overdenture, and with a bar, you got so many options. It's awesome. The biggest disadvantage to that is that it's difficult to clean for most patients. So with an individual abutment type of an approach, it makes the hygiene aspect for the patient just a million times easier.
Mm.
So um, the approach that I like is going to have individual abutments that are going to be milled with a common path of draw, usually at 1 to 2 degrees of taper,
Mm-hmm.
and then an overdenture that's going to fit over the top of those abutments, and it's retained only by friction. So the patient is able to take it out. They can clean it at night. They can clean around the abutments. They can clean inside the overdenture, and then they reseat it. And once that denture is seated, it's going to feel to the patient like it's totally fixed.
Now, what do
Yeah.
you feel like that how much vertical height to the abutment to provide enough resistance form for the case? Let's say that you had, say, 5 to 6 implants in the maxilla, and you were paralleled all those abutments. What's your ideal abutment height?
There's some ways that you can control that. So each kind of connection, right? So each abutment with the coping is going to give you somewhere between 2 and 5 newtons of retention.
Okay.
And you can alter that by either adding more abutments, so that means adding more implants, or you can reduce the taper, so going from 2 degree to 1 degree. And then the other thing that you could do is increase the height of the abutments.
Gotcha.
Okay.
So you're not using, like you say, a conus approach. So the thing, and I know I'm about to dive bomb the rest of the show with
don't
time,
do
but,
it, John.
But I have
You're
to
gonna
ask,
do it.
okay,
I can
because
see it in your
I'm wanting
face.
to so bad.
Yeah,
I
you're
know,
gonna
but
do
the
it.
okay, so the challenge, with this approach, at least for me, is not whether it's awesome, okay, because I think it's awesome, but to me the challenge is there's a lot of gymnastics going on in the temporary and the provisional prosthetic, and and you have to potentially either you're working on a verified model and you're installing and uninstalling abutments, or you are picking up these abutments in your provisional, which requires the same type of vertical and support and not fracturing stuff. And are you luting copings intraorally? There's a lot going on with that has, I think Conus, for instance, is put out there as, it's a great alternative. But there's a lot of, so how are you managing, and I don't know if you want to
That's exactly
go into
how
all
I
those
got
details.
interested in this approach, because Conus was, the marketing for the prefabricated telescopic approach was sounding so great. And then all of a sudden people were asking me questions about, like, I'm not even sure how I'm supposed to sequence all the appointments here.
Yeah.
And the reality is it's technically super challenging.
Okay.
And so that's
I'm glad you're saying
us.
that. It's making me feel better.
Yeah, because that's what we're thinking. Like, whoa.
Yeah.
I mean, I think it's awesome. It's just I'm glad to hear you feel like, okay, this is tough.
I was hoping for a secret door you would open and be like, oh man, like
let me show you
that's
this.
the next episode.
Oh,
Actually,
man.
you have to come to my
Like it.
workshop, and then everything's fine. You guys, you'll get it.
So I mean, so those things that I mentioned, those are challenges that you're facing too with this approach. It sounds like.
Yeah,
John, I think
this is. I know technicians. In fact, I was just talking with a master technician over the weekend who said he's not doing it anymore because it's just so difficult in the lab, not fun for him.
Gotcha.
So
let me just say this: is I think this is a perfect conversation. Just this particular thing alone, it intrigues John and us. This whole conus concept, because we have geeked out about this for the last 2 years.
Yep.
And
I was up at the Astra headquarters. Okay, when they released this thing, we were at just a CE meeting. It wasn't like I'm like some special guy, but
You are.
I was just up touring
You're
the
special.
factory, and they were like, "Let me show you this new thing. It's amazing." And they put it out there, and I was like, all these people are so excited. And then they presented at the AO podium, partially because they don't have a freaking multi-unit at that point.
Watch
so
it.
what are they gonna? They're not going to talk about multi-units because they didn't have one. But anyway. And they had like 3 or 4 speakers from, AstroTech and talking about it. And immediately it's like, whoa, hold on. Luting copings intraorally. Let's just dive into just that one thing for a moment. For the typical practitioner, that's pretty scary. And when you ask the labs, how many people are luting copings, splinting them, they're like, nobody does that, And so,
Right.
but then if it's not a passive fit, blah, blah, blah. So I think Wes was going with this is a show.
This is a whole show.
I need to just stop
we
talking
need to
about
stop right
yeah,
here.
it really is a whole show, because I mean, like, guys, we just finished this 3-day workshop on this stuff, right? Treating adventitious
Okay.
patients. And in that workshop, like we're kind of doing what we've done in these 2 episodes. We're talking about a bunch of different options, and how do you make sense of that as a clinician?
Yeah.
It's tough.
How do I figure out what's going to help my patient the best way?
Yeah.
But
right.
for
But the
this
short of it,
technique,
Darin, is that if you have all the options out there, knowing that this is a technically complex option, it's still, you feel like if you've got that option, this is kind of your go-to.
this is what I'm most interested in right now. This is,
I like it.
if I'm going to make an
we are too.
overdenture, yeah,
It's
this
cool.
So
is-
let me move on to some interesting
Yeah,
things.
please,
that we wanna
Wes,
talk
take
about.
it.
Yeah, I'm just going to go ahead and just take this show right
take
now.
it before I.
so you're looking for
Destroy it.
something more interesting than
Well,
that?
no, it's not. And
No,
you know
there's
it's not, but it is.
No, I don't
Okay,
know.
so-
Let's see. Tell me what you got.
Okay,
Let's go.
so let's just answer this question once and for all.
Yeah.
If a flange
Yeah.
if a flange is indicated for lip support, Darin,
Yeah.
when would you do a fixed restoration?
Well, I think that's. I mean, I got an
Come
hour
on.
program on that. If you need a flange, you need a flange. So your options are either you accept diminished aesthetic outcome, or you make a flange. And if you make a flange, it's going to have to be an overdenture, right? It's got to be removable.
So you're saying never unless
Yeah. So the answer is never. Is that
never.
The answer is never. If you need a flange, you need removable. That's
Okay,
you-
let's
you
go on to the
cannot-
next question. That's
Yeah.
done.
Yeah.
Yeah.
Problem
Done. We
solved.
like it.
Okay.
We just wanted
Now
to
there's
hear
another
it because
time you might want to use removable though, and
Okay.
that I think a lot of people miss. So the first obvious one is if you need lip support, but one that's less obvious that can surprise you negatively is the person with a gummy smile when they had teeth. So a person with a short upper lip or a hypermobile upper lip, if we position the teeth where they're going to work aesthetically for the patient, and we don't evaluate what their lip can do, we might go fixed and then wind up having the prosthesis tissue junction, the pink transitioning back to the natural ridge where it's visible. And
Yeah,
if
it's a
you
no-no.
get that horizontal
no-no.
transition visible, that's a bad day. So those cases, one option is to go through a flange, go with removable for them.
But I think the reason we maybe our like motive with asking you about that is because we are seeing so many flanges on fixed restorations being and it's just a big problem. We think that this may be the big problem, and I think some of it's a surgical problem, with the lack of just reduction, and then some of it's a surgical problem with maybe not planing bone properly. But then a lot of it is just people are like, I gotta nail, I'm gonna nail everything with the same hammer.
John, I think we
it's
got
a
one
treatment
last
planning. It's a treatment planning problem.
It is. You're exactly right.
Yeah, completely.
It is. It's lack of understanding of the full on treatment planning process for these things. I want to go to one last question because I did plug this show maybe a week or so ago with a quote from Compendium this past month. In Compendium, it actually is in the September of 2017. We talked about, and you mentioned, and they mentioned, is that should we be using in our full arch implant cases two opposing materials such as zirconium and denture teeth? Now, Darin, you mentioned that it was one of your go-to favorites for fixed over fixed. And should we be planning two dissimilar materials for the upper and lower arches? What's your thoughts on that?
I don't know what the compendium say.
Well, there was three. Okay, there
That's
was
cheating.
three. It was. I'll tell you, there was three people that was interviewed. Dr.
Ed
Greg.
McLaren was one of them, so we
Yeah.
got to go with Ed, right?
Right.
You're a UCLA guy.
Yeah,
Exactly.
so,
Whatever McLaren says, I say. He's the guy
Right.
who knows everything.
Greg Helvey, okay, and associate professor of general dentistry, Virginia Commonwealth, then he talked about that highly polished zirconium surface will have minimal wear effect on opposing denture teeth, and he used the fact that the wear resistance of zirconia is reported to increase by a factor of 8 when the grain size decreases from 1.5 microns to 0.18 microns. Basically, polished zirconium, when you're using proper zirconium, has no wear or minimal wear to high quality denture teeth. Dr. McLaren said that he preferred using like materials in his, and if I'm right in saying that, John, I would probably, he says, recommend zirconium against zirconium and accept the clank. And then one from Dr. Moore, which was a private practitioner, and he favored to he kind of said monolithic zirconium against monolithic zirconium as an option, and basically the patients often complain, but sometimes they adapt, sometimes they don't, and it is a problem.
Yeah, imagine you've just put in upper and lower full arch zirconia, and then your patient comes back in 2 days and says, I cannot stand the way that it sounds when I bring my teeth together.
Yeah.
That's a bad day, because you're going back to the drawing board. You're going to have to replace an arch. And you're going to be replacing a really expensive prosthetic design with something that's a little bit less expensive. So the risk with wear, I think, when zirconia first came out as a crown and bridge material, everybody was worried that it was going to be too strong and that it was going to overpower, let's say, enamel, right? And there's plenty of studies now that if it's hand polished, not glazed, but if it's hand polished, you'll smooth the material enough that it's not going to wear anything any faster than enamel would.
Yeah.
So the problem with denture teeth is that they're plastic and they're going to wear no matter what. So you take your conventional denture patient, somebody who doesn't have implants, what happens with those guys at 7 to 10 years?
Yep.
You got to replace them because the teeth are worn out. And so if we're going to be using plastic teeth, we know they're going to wear out. Happens if you have fixed hybrid versus fixed hybrid. So if I know that that's going to happen, that's all of a sudden, that's not a failure or a complication. That's expected maintenance. And what I'm trying to do is give a outlet for some of the force that's going to be involved in the upper and lower jaws coming together. I'm trying to give that force a place to go rather than destroy something quickly, like have your full arch of zirconia just come apart. That's a bad day. But if the teeth wear out slowly, rather than have an explosion of zirconia, you've got just this little simmering fire that's going on with the plastic teeth. And that's pretty easy to replace. So that to me isn't a big deal. So that's,
and it also gives you, I think, it also gives you an indicator of if there's a problem with the occlusion. I think that it's easier to see that, if you break a denture tooth out of a fixed hybrid. I kind of joke about this, that it's actually a kind of a good day in a way, because you learn something about what's going on. And, if you have zirconia and you don't have that feedback, what's going to happen? A patient isn't going to have pain like occlusal trauma. They're not going to be aware. Are we going to debond a titanium cylinder? Are we going to fracture the zirconia prosthetic? Are we going to induce stress in the implant connection, which there's some discussion about that as well. I think I like the idea. But the thing I don't like, of course, is I don't like the staining and I don't like the smell, and patients, challenged to sometimes clean it. Right. It's definitely a trade-off, but I think your point's well taken, that if you're going to have a failure point, you want it to be the most favorable failure point. And I think especially with the fact that you mentioned earlier, we only have 3-4 years of multiple arch data on zirconia, maybe 5 years of, say, case reports, but not, prospective or even retrospective studies that have a high N. So we got to figure that we don't really know exactly what the failure is going to be. Exactly. And I certainly like that idea. This is, man, I'll tell you, Darin, this is some high level stuff. It's
another great show.
Another great show. And I really would love to have you back. We'll talk more later about this, to maybe dive in a little bit more to the restoration that I really wasn't expecting you to say. The telescopic
really caught me off guard.
abutment. Really, I'm really excited to maybe talk more about that. In the future.
Guys, if you right now are in the audience and you're listening to this as a podcast, you have to make sure you go and watch the video because these guys are stoked about this topic right now.
Yeah, you can tell. Like I'm sitting up in my
Body
chair.
language is like, man,
Let's bring it. But
And we're
no,
talking about overdentures, and they're like lit up like it's the 4th of July. It's
we
awesome.
have
go
a
to
problem. We know we have a
YouTube,
problem.
YouTube, check us out on YouTube.
Yeah.
Yeah.
And I want to just, for everyone that's listening, obviously you guys have heard Darin now 2 times on our show. You know the kind of knowledge that he's bringing to bear just with us today. We know that Darin mentioned at the beginning of the show that he is teaching a couple different places at Spear, both with the advanced workshops and then with his kind of more focus on the treating the terminal dentition, the fully edentulous patients. He's got the seminar. He's also got the workshop. If you want to check out where he's teaching, when he's teaching, go to speareducation.com and look him up. Check him out. We would love to, if you want to learn more about this, obviously the place to go is to the source, not to us. This is just giving us some discussion, and it gives you guys a starting point to really get into this. If this is something that really is you may not think it if you're not currently doing this in your practice, but I guarantee you it is in your practice. And if you want to know how to treat these cases with confidence, you're not going to get it from a podcast. You're not going to get it from YouTube. You're going to get it from high quality education where you're there and you're getting somebody who's looking over your shoulder and telling you how to do this right. It's not easy. And I think you keep hearing this theme in these discussions is this stuff's not easy, but it's not supposed to be easy. We're supposed to always be looking to make things better. So go check Darin out. And Darin, thank you very much for being with us on the show today.
Thank you so much.
It's been a lot of fun.
Thanks for having me back, guys. It was great. I love being with y'all.
And we also want to just remind our listeners that to go and check us out, connect with us, tell us what you thought about this episode. If you want to hear more from Darin, let us know what you want to hear more about. We're always trying to get our topics focused on your feedback. If you have questions for us about some of these topics, or you want to learn more about some of the research we've been talking about, we can send you some articles and things. So go to Facebook, check us out there, give us a like on Facebook. Check us out on iTunes. Give us a positive review. That really bumps us up so people see our podcast on iTunes. Go to YouTube and check out the video. Hit us up on Twitter if you got questions. We really want to make sure that we're always connecting with our listeners, and we're excited about what we're able to get, how we're able to get involved with Spear Education. It's really been a great thing for us to be able to partner with you guys and to really take things to the next level with a type of people we get to speak with. So for Wes and John and Darin, we've enjoyed this time, and we'll be back next time. We are the Dental Guys.